Good morning, everyone. Thank you for joining us today. This is part 2 of SARC's Ignite Summer Speaker Series brought to you by BHHS Legacy Foundation. To best manage today's events, all participants are automatically placed on mute. You do have the ability to use the chat function, which you'll need for some activities. With question and answer, there is a separate Q&A box, and I'll direct you to ask your questions in that Q&A box. Thank you again for joining us, and I'd like to introduce you to our speaker, Dr. Lori Vincent. Lori Vincent is an assistant professor at the School of Psychology graduate programs at the University of Cincinnati. Dr. Vincent received her PhD in educational psychology from the University of Wisconsin-Madison in 2015. And completed her psychology internship and postdoctoral fellowship at the Kennedy Krieger Institute, Johns Hopkins University from 2014 to 16. She is a licensed psychologist, board certified behavior analyst, doctoral level, and a certified Ohio behavior analyst. Dr. Vincent's primary research interests include teacher and parent implemented behavioral interventions for children with intellectual and/or developmental disabilities. Specific areas of her research include social skills interventions, positive behavior supports, and behavioral feeding therapy. Without further ado, I'd like to introduce you to Dr. Vincent. Lori, it's all you.
Thank you, Rachel. I am very excited to be presenting to you today for several reasons. The first being that I had the pleasure of working for SARC prior to going back to school to get my doctorate in school psychology. And actually, when I was working at SARC as an in-home ABA program manager, that is when I developed an interest in feeding interventions. So this is very exciting that now I am coming back to SARC to talk about feeding interventions. And as Rachel mentioned, I did my internship and postdoctoral fellowship at Kennedy Krieger Institute. If anyone was able to listen to Stephanie Brown's talk last week, I had the pleasure of working with her while I was there. I worked specifically in their pediatric feeding disorders clinic. And the other reason that this talk specifically is very exciting for me to be giving here at SARC is SARC is where I developed my interest in parent training. So I was able to work with the incredible clinicians at SARC and learn about parent training, specifically with pivotal response treatments. But parent training has been a primary focus of my clinical and research work. And so today I'm going to talk about feeding interventions, but I'm going to focus on parent implemented feeding interventions. So next I'm going to talk about the objectives. So the objectives today in the talk, first I'm going to go over what are some evidence-based strategies to address feeding concerns. And then I'm going to go through 3 different case examples that will highlight, and they're all interventions that I did in an outpatient setting. So I provided the parent with tools that they would then go home and implement to address feeding concerns of their child. During those case examples, I'm going to stop after each one and there's a spot for questions. If you have questions specific to that case, I'll take it at that time before we move on. If you have broader or general questions, Rachel's going to hold those until the end and I will answer those at the end. So first, I just wanted to talk a little bit about what is a pediatric feeding disorder. And so a child with a feeding disorder is unable or unwilling to consume all the food and or drink orally that they need to meet their needs. So this could be a child who has a tube dependency. It could be a child who is drinking Pediasure or other like supplement to meet most of their dietary needs. It could be a child who is underweight, who has what's called failure to thrive. In my time at Kennedy Krieger, there was a time in our intensive program that actually every child in our program, which is about 13 or 14, they're actually all overweight, which is not what you would expect with a feeding disorder. But all of those children had such a selective diet that they weren't meeting their needs. So that's where that significant food selectivity comes in. So they weren't able to meet their needs. And a lot of the foods that they were eating were higher caloric. So again, you may not think of that as being a challenge, but certainly having a feeding disorder doesn't necessarily mean that you are underweight. You can also see a lot of inappropriate mealtime behaviors. So things like crying, screaming, falling to the floor, getting up from the table, pushing the bite away, turning the head, aggression, self-injury, any of those behaviors that interfere with mealtime behavior. It's estimated that 25 to 35% of typically developing children have mealtime difficulties, and 33% of individuals with developmental disabilities, although I've also seen much higher numbers for estimates. And in one study, they found that 89% of children on the autism spectrum exhibited a strong preference to certain foods that were either based on color or texture. Another challenge that can often come up is maybe it's not just the foods. It may also be that they only eat with certain utensils or certain cups, which can also be incredibly challenging for families, especially I worked with a family who had a 14-year-old who only drank from a certain sippy cup. And when they discontinued that cup, he met all of his needs through liquids, through Pediatric, and refused to drink. So that can be an incredibly large challenge for families. I wanted to give a little bit of an overview of what kind of feeding services are out there, and specifically more focused towards the behavioral side. There are several programs throughout the country that will do interdisciplinary evaluations for feeding. Kennedy Krieger, where I did my training, was one of those. So you would have a team that included all of their different disciplines, looking at the child's feeding behavior, getting information from the parent, and providing recommendations. There's also intensive programs. So there are several day treatment programs, just to name a few, although there are several more. The Kennedy Krieger Institute, Marcus Autism Center, Monroe Meyer Institute, amongst several others, have more intensive day treatment programs where a family will go for the entire day and the child will be there for 3 meals. Typically those programs, they start working with a therapist. And then as the child is progressing in the program, the parent is implemented later and providing more feedback, more parent training at that point. There is also some inpatient programs. To my knowledge, Kennedy Krieger is the only behaviorally based feeding program that has the inpatient option. So for instance, I worked with a child who, she was 5 years old and had 3 different organ transplants to date and was G-tube dependent. So she was in the program to work on that tube dependence. And because of all the medical concerns that she had, she actually stayed at the hospital overnight and would go to the day treatment program. Other families would just come for the day and then stay somewhere else. Typically, those programs are between like 6 to 8 weeks. So that's a pretty significant commitment for families. There's also many different outpatient services, and depending on the needs of the child, different providers would be appropriate. So nutrition, occupational therapy, speech and language pathology, psychology and behavior analysis. And then there's also the medical side of feeding concerns. And so certainly doctors and nurses and nurse practitioners are an important part of a feeding team if those concerns are there. So I wanted to start by talking about some evidence-based strategies, and these are what we call consequence-based strategies. So what we found in feeding research is that a lot of times inappropriate mealtime behaviors occur because the child is trying to escape or avoid. Typically it's the food, but sometimes it might be sitting at the table or in the high chair. It could be using certain utensils or things, but there's usually some strong component of escape. That this behavior is persisting because I am able to avoid the thing that I don't want to do. There are also times that you may see other functions of challenging feeding behaviors. For instance, I worked with a family who had been through an intensive program and they had a treatment protocol, and part of that protocol was that they had an iPad that the child was able to watch if they were taking their bites. But the family didn't really want the child watching an iPad during the mealtime, which is understandable. So when they went home, what they ended up doing was they would feed the child, and if the child refused to take a bite, would then bring out the tablet to show the video. And what happened was that increased that refusal because the child really wanted to watch the video. But the only way to access it was to refuse. So once that child realized, if I refuse, I get it. So they saw this big increase in refusal and didn't understand why. So when we looked at the function, it wasn't actually about escape. That was about getting access to the tangible or to that iPad. So we were able to come up with a different plan that still the child wanted that tablet. So we started with, after you take a bite, you can have it, and then increase gradually until eventually they only got the video at the end of the meal, which met the family's needs that they didn't really want technology as part of the meal. So they were able to kind of continue that appropriate mealtime behavior, and we were able to fade that out systematically instead of giving it in response to challenging behavior. But as I mentioned, most of the time, most inappropriate mealtime behavior occurs in order to escape or avoid what you don't want. And so in order to address it, the most effective way that we know to address it is what's called escape extinction. So you used to be able to escape your bites when you push the bite away, but now I'm going to keep it there. It doesn't just go away. This can be highly effective, but there are several challenges with this. That can be really easy to implement in an intensive program where you have a lot of staff support and therapists are implementing 3 times a day this intervention. But what happens is challenging behaviors increase before they decrease. And so if I'm working with a parent in an outpatient setting and I'm sending them home with strategies to try, but I'm not there to help them through that, it's a really challenging thing to implement. And so I'm going to talk through my case examples, different ways that I've modified. We still have components of escape extinction, but a little bit different from what we find in the literature, which tends to come from those more intensive programs is where we're getting a lot of the research. But that extinction is a really important component that if I continue to just be able to escape what I don't want to do, then I'm going to continue with these behaviors. But there are other strategies that we can incorporate in addition to that or in place of that. One being positive reinforcement. So if you take your bite, you're going to get something that you want. And I've worked with a lot of families that will say, you know, I told my child they could have an Xbox if they just eat their vegetables, and they won't do it. And so there's a couple of different things to consider with reinforcement. One, you got to consider the history of reinforcement. In the past, if you've said, if you do this, you get this, has that been the case? If it has, then there should be that history of reinforcement. But if you haven't always, that might be the first place to start. The other thing is just, I could say to you, if you go out and run a marathon right now, I'll give you $1,000. $1,000 is a good amount of money, but if you're not a runner, that's a big task. So if you're asking a child who doesn't eat vegetables to eat an entire portion of vegetables, that is a big task. If I said, if you run to the corner, I'll give you $1,000, I bet most people would do that, right? So we have to think about how big is this demand, or in a lot of cases, how aversive is this to this child? Not, I may not think taking a bite of a pea is a big deal, but to this child it is. And so we kind of have to think about, what are we asking? What is the demand? What is an appropriate reinforcer? What's going to be motivating enough for that child to do that? And then we're able to kind of build from that over time. The other thing with positive reinforcement that I do a lot with feeding interventions, I tend to use non-food related rewards. Especially, I work with a lot of children who may only eat 2 or 3 foods. So if I say you can only have those foods if you take a bite of something else, well, then they may have nothing to eat. And that's not a situation that I want to put a family in or a child in. So we may have those foods at a separate time. And when we're working on new foods and exposure, we could do something like a video or access to preferred toys or going outside, something that's still going to be immediate, because immediacy is also really important, with reinforcement, but something that if the child chooses not to take that bite, it's something you can withhold for the rest of the day or until the next opportunity to take that bite. You don't want to be offering something that, ultimately that child needs at some point. Negative reinforcement it's still reinforcing inappropriate behavior, it's increasing. In positive reinforcement, you're giving something for the behavior you want to see. In negative reinforcement, you're taking something the child doesn't want away. So I've used this a lot in feeding, especially around self-feeding. So I worked with a child who could self-feed, was 6 or 7 years old, physically was able to do it, had mastered that skill, but was wanted to be fed rather than to take the bites themselves, which is challenging when the child's about to go start school and is expecting other people to feed him. So he could avoid taking bites of non-preferred foods by self-feeding a bite of something highly preferred. And we were able to build on that over time. But basically you get to avoid something you don't want by engaging in the behavior that we want to see. When you're providing reinforcement, if you provide reinforcement for every single bite, that can make a meal very long and challenging. And so token economies can be great if the child understands, okay, I take a bite, I get a token, and then I can turn those in at the end of the meal for something that I want. And a lot of times parents understandably don't want videos and toys as part of their mealtime, especially as it's often family time. But tokens are something that you could provide during that meal without interrupting the social time of the family or focusing on the meal. As a punishment procedure, so that's to decrease inappropriate mealtime behaviors. In the case of token economies, you can do something called response cost, that if you're getting tokens for taking your bite, but if you engage in inappropriate mealtime behavior, I'm removing a token until you take that bite, and you can still earn it back, but it's the removal of something to try to decrease those challenging behaviors. So those were all consequence strategies. Those are things that we are doing in response to certain behaviors. A lot of what I focus on with parent training are called antecedent strategies. These are things that we're changing before any behaviors occur in the mealtime. So one strategy is called non-contingent reinforcement, and really it's non-contingent access to something preferred. And the way in which this can be really beneficial with feeding, what we found in the research is if I give the child access to preferred items during the meal, regardless of whether they take bites or not, it tends to decrease challenging behaviors. And if you are having a mealtime with your child where there's screaming and yelling and crying and all of these things going on, it can be very stressful to the child and to you, which isn't going to increase the likelihood of taking bites of non-preferred things, right? So that non-contingent reinforcement, bringing in preferred activities that the child can have whether they take the bites or not, can really decrease some of that stress and that anxiety and those inappropriate behaviors. What it does not tend to do is increase bite acceptance. And I have an example of this in one of the case examples. One component that I tend to include in almost every feeding intervention that I do is some form of choices, as long as the child is able to make a choice. Children throughout their day, we are giving them expectations, telling them what to do, when, how to do it. And kids want some autonomy and some choice, and especially when it comes to meals. And so that doesn't mean free choice and be a short order cook for your children and whatever you want, I will make, but providing a finite number of choices. You can decide, do you want carrots or do you want the broccoli for dinner? And sometimes just providing a choice, even between non-preferred items, can increase compliance for a lot of kids. Simultaneous presentation is when you present 2 bites, a preferred and a non-preferred together. This is typically done with what we call lower texture foods, so something that you would blend like a puree texture, because you can easily blend things together. But you can also do it with regular texture, table texture food, so you could have some rice with a little bit of chicken in the bite. This is one that I actually don't use very much. There is some some nice research support for it, and I have one of the case examples. We'll talk about how we use this. The idea behind it is that if I pair a non-preferred food with a preferred food, that the non-preferred food will become more preferred over time. And you can start with just a tiny bit of the non-preferred and build up and eventually fade out the preferred food. And it can work really well for some kids. The challenge is you may also be pairing a preferred food with something the child really doesn't like, and they may actually eliminate that preferred food. So again, I've worked with a lot of kids that may only eat 2 or 3 foods. So if they're only eating goldfish crackers and Oreos, I tend to not use those in my meals as reinforcement or pairing with other foods, at least initially, because if they eliminate one of those things, then you're down even more foods. Another component that I tend to include in almost every intervention is what's called behavioral momentum. And this is the idea that if I am complying with tasks, with easy tasks, I'm more likely to do a harder demand than if you started with the harder demand. This has some mixed support and research, but I will say from my clinical experience can be really effective. And I have used behavioral momentum in a couple different ways, and you'll see in the case examples. I have done starting with bites of preferred foods. So you're taking your bites, you're getting reinforcement, and then we introduce the harder food. And that child has that relationship with the reinforcement. I know if I take my bite, I get what I want. So you're building that up. I've also done it with empty spoons. So making the demand pretty easy. There's nothing on the spoon, nothing on the spoon. And then I'm just putting the tiniest bit of the non-preferred to build that momentum. I've also done it with non-food related tasks. So we're going to do a matching task. We're going to do some other things and then work up to food related demands. Another strategy that can be really effective is visual supports. So the picture here is a visual support actually from an intervention that I did while I worked at SARC. And here the child had 3 different colored plates, and there are 3 different foods, 2 preferreds, 1 non-preferred. And for each bite taken off that color plate, the corresponding color token would be removed. When all the tokens were gone, then the child got the reward. So you see the first then, and that was visually shown to the child so they would understand that. We can move on to the, thank you. So the last 2 strategies I wanted to talk about, shaping is one that I use all the time. And so I gave the example of if I ask you to go run a marathon right now, even for, a big prize, if you're not a runner, you're probably not going to do that. But what you can do is start with just a short distance and build up until you get to that place. And so if your child is not eating any vegetables, to put an entire portion of vegetables on their plate is overwhelming. So it's not surprising that if I'm overwhelmed by this task, that I'm not going to engage in it. So you may start with just one piece of that vegetable on the plate and see if you can work up to eating, and then start to gradually increase it. So we're starting at the place, and where you start shaping depends on that child. At what is this child willing to do right now? And how can we build on that to get them where we want them to go? Another strategy you can use is prompt fading. Mostly I've used this with self-feeding. So I'm going to physically prompt you to be able to engage in this behavior, and then I'm going to gradually fade out my prompts until you can do it on your own. So now we're going to get into the case examples. So my first case example, this was a little boy that I will call Jeffrey. He was a 2-year-old Black male. He was diagnosed with an unspecified feeding disorder and developmental delay. He was seen by an interdisciplinary feeding team, and they recommended that he start with outpatient psychology services because he had not received any feeding therapy. But because of the significance of his feeding challenges, they said pending progress that he might actually be appropriate for the intensive feeding program, which again was 6 to 8 weeks, 5 days a week, 3 meals a day. So that's about 15 hours a week of intervention. At the point of the data that I'll show you for this case, he had 19 1-hour outpatient feeding sessions. So if you think of that from a cost perspective for insurance and time perspective for the family, this would be just over a week of an intensive program. So Jeffrey, actually, his mother was amazing at meeting his nutritional needs. So he was still eating everything from a baby bottle, but basically what his mother would do was puree a whole bunch of different things, Pediatric, applesauce, I can't remember all the things. But when our nutritionist looked at this, they said, wow, you are meeting all of his needs. So nutritionally, his needs were being met, but he would only eat from a baby bottle. And really it was this thick puree that he was having. So he wasn't eating any foods by spoon. It was all, or drinking from anything else. It was just from that baby bottle. So our target goals, if you presented any sort of food, he would push it, turn his head, cry. So we wanted to decrease that food refusal. We wanted to increase acceptance of bites from a spoon. We wanted to increase drink acceptance from an open cup. We did open cup first. It's a little bit easier from my experience to teach with an open cup, although you can do a straw or a sippy cup, but the open cup just gives you a little more control. So we were starting there and then working on transitioning. We did actually transition him as well to a sippy cup. And then we also had the goal, because what he was drinking was very, it was what's called a puree texture. It's like yogurt. It was very smooth. And so any food that had any texture, he would avoid. So we wanted to add in some texture into his food to hopefully get him eventually to chewing and eating table textures. And so based on the meal observation and parent interview, he would engage in inappropriate mealtime behaviors, which for him was crying and screaming, pushing the spoon away and turning his head until the bite was removed. So the function of that behavior was escape. So for the intervention components, this is a case that we used escape extinction for a couple of reasons. One, he was 2 years old. He was in a high chair at home. So one challenge of escape extinction is that for really small kids who are in a high chair, they can't escape, right? They can't get up. So you can keep the bite there. As kids are no longer in a high chair, they can get up and leave. And I try to avoid at all costs having parents have a physical altercation trying to keep their child at the table. So that's when I tend to modify escape extinction, which we'll talk about in the next case example. But because he was very small and mom was able to present the bite to his upper lip and keep it there, if he tried to hit, she could just kind of gently block his hands down so that the bite stayed there until he took it, or we hit a time cap. This is something you would typically do in an intensive program, but have a very long time cap. Like it could be, up to like 45 minutes. But that's not realistic to send this mother home and say, just hold a spoon there for 45 minutes or until they take the bite. So I modified it, and our time cap to start was 1 minute. So if he didn't take that bite in 1 minute, then that was discontinued, and they'd try again the next day and then come back to therapy, and we'd come back with a new plan. But what we started with was an empty spoon. There was no food on that spoon. So basically he just needed to open his mouth, mom put the empty spoon in, yay, and he gets his reward, access to a video. So we started with that empty spoon to build that momentum. We started with 5 bites, then 10 bites from the empty spoon. We then went to a dip spoon, and what we found for him was he had challenges with lip closure. So he had never eaten off a spoon. So he didn't know really to close his lips. So when we had the dip spoon, we could get the bite in, we could get the spoon out, but the food did not come off the spoon. So that sort of defeats the purpose. Teaching lip closure is really challenging. You can try to physically prompt. That's not an easy thing to do. What we found in his case, and I was able to consult on a different case later, and this worked as well, when he would let the spoon in his mouth, if we just sat the spoon on his tongue and gently provide a little pressure, not much, but just push down a little bit, his lips would close and then we could pull the spoon out. That probably isn't going to work for everyone, but it worked really well for him. And then once he was clearing the spoon, we were able to go to a half level spoon and then level spoon. I really like in therapy to use, there's a picture here of the maroon spoons. You can buy them on Amazon. I am so comfortable with them that when I had my own daughter, that's what she ate from, because that's what I'm very comfortable feeding with and have done for 10 years. So we can move on to the next one. And one reason I wanted to say to keep this amount of food on the spoon consistent, or what we call the bolus size consistent. If the kid's used to taking small bites and sees a big bite coming their way, you're probably more likely to see refusal. So you want to kind of try to keep that demand consistent until you've worked up to a larger bite size. So this is a graph showing across our sessions the number of ounces. So he was drinking 8 ounces. And because this was a thicker food, we actually kept the food the same. We just transitioned from the bottle to the spoon because it was actually a very thick texture. And so you can see for the first 6 sessions, 100% of the amount that he was consuming was coming from the bottle because we were working on empty spoons. But then once we were able to start introducing some bite size, we gradually increased how much he would eat off the spoon, and then he'd drink the rest from the bottle. And as you can see, as we were able to gradually increase the volume, eventually he just started eating all of it off the spoon, and we were able to fade out the baby bottle for that food specifically. The other component was, so this was a very flat texture. Like I said, it was like a yogurt or what we call a puree. If we wanted him to eventually get to eating regular table food, he needs to be able to handle some different texture in his mouth. And so we moved to what's called a junior texture, which is applesauce, which to me doesn't seem that different from yogurt. I've worked with a lot of occupational therapists who tell me to kind of feel it in your mouth and feel what that experience is, because it is different. For a lot of us, we don't notice that sensory difference. But for a lot of individuals on the spectrum and some typically developing people, it is a big difference and a big difference in the experience. So we gradually faded in junior texture because applesauce is a natural junior texture. You don't have to blend it to get it to the right texture. Which I will say in my time in intensive feeding programs, blending is not my strong point. It was very hard. They have very specific textures to get to. And that was one that was always a challenge for me. So then teaching parents to do this at home is challenging. So I tend to start with foods that are naturally at the different textures. So applesauce, and then oatmeal is what's called a wet ground. So it's the next texture up. So I like to use foods that are already at that texture. So it's a little less work for parents. But we started with 75% of the puree with just 25% of the applesauce, and we're able to increase. We had some challenges with him spitting the bites back out, but we're able to work through that with representing the bites. And he could take up to 10 bites of applesauce without mixed with anything else and without expelling the bite back out. So that was very exciting progress. This is a graph that's showing the average latency, so how long from the time we presented the bite until he accepted the bite into his mouth. So the blue line is showing the empty bites. The red line is showing that puree texture, and then the green is showing that junior texture, that applesauce. And so you can see initially 150 seconds to accept an empty spoon is a long time. And we saw a decrease in that. The reason it increased again was because we realized he wasn't closing his lips. When we introduced that dipped spoon, we realized that he was taking the bite in his mouth, but he wasn't actually clearing the food off the spoon. And so you see at session 6, this large increase in how long it took to take it, because we only counted it when the spoon was clean. And that's where we kind of had to try some different things to get him to be able to close his lips. But we figured out something that worked. His mom went home. She worked on it for a week and came back, and we saw that really big drop in how long it took him to accept bites. And then after a couple sessions, he was taking them immediately. And even once we introduced that junior texture, it increased a little bit the latency, but never back up to those beginning, how long it would take for him to take that bite. So the other thing that we worked with him on was drinking from an open cup, because this was great. He could now eat some foods off a spoon. That was really great progress. But what about drinks and beverages? And so I had just gone to a conference and saw this incredible presentation on how they took a cup. It was a child who was only drinking from a syringe. So this family was syringing in all of this child's liquid in a day. So time consuming. And what they did was they attached the syringe to the cup. So the syringe was sticking out and the liquid would come from the syringe, and they gradually moved the cup up until they were even, the syringe and the cup. the liquid was still coming from the syringe, and then they switched to the cup, and then they faded out the syringe. So cool. So I came back and thought, we're going to do this fading with a baby bottle, and we're just going to kind of cut down the nipple until we can get to a cup. Huge disaster, did not work. So sometimes you try an intervention and it just doesn't work. This was that example. So what I came up with when that didn't work, because this was such a thick puree that he was used to drinking, we just put it on the lip of the cup, and all he had to do was take the liquid off the lip of the cup. So that's what we started with. And we also started with, for the reinforcement, the non-contingent access. Basically, we distracted him, touched the cup to his lips, and if he got the liquid off, then there was lots of praise. And then we started to do contingent access so that he could understand that that's the behavior we wanted him to engage in, to take that liquid off the cup. And again, this is something that he liked. He liked that food, just not coming from a cup. As we started, so I gradually faded where the liquid was coming from in the cup. The challenge was this was a very thick mixture, and it was like molasses pouring out, and this little 2-year-old did not have the tolerance to wait for it to come. So I started mixing in more Pediatric to get it thinner so it would run more quickly, and then we faded out the other stuff so he was drinking his Pediatric. His mom actually ended up giving him soda. He had drank some of hers, and he was doing such a small volume, he actually would take that really well, and so she was able to get him very quickly taking drinks using that. So this is an example of outpatient therapy in that I can't always take the best data. So we have a lot of sessions that I didn't get the data in, but we do have that baseline of how long it took him to take a drink before we start our intervention. And then you can see it gradually, significantly decreased once we started our intervention, how long it would take from the time we presented the drink until he took it. Okay, so we'll do a quick pause for questions. I don't hear any, and I'm running close on time, so we'll just keep going if that's okay.
Yes, you can keep going.
Great.
We just have specific questions that we can do at the end.
Perfect. Okay, we'll go on to the next one. I want to make sure we get to those, so I'll probably run through the next two pretty quickly, but Rachel, just jump in if someone has a specific question about the case. Will do. Great, thanks, Rachel. So the next example is Ethan. He was a 5-year-old white male. He had significant feeding challenges, and this is a family who had tried feeding therapy in a lot of contexts, and actually he would eliminate more and more foods. He also had a diagnosis of autism spectrum disorder. He participated in a brief intensive feeding treatment program that I had helped develop while I was a psychologist at Cincinnati Children's Hospital. And so what we offered there was 2 appointments per week for 12 weeks. So it was a little more intensive than the weekly of the previous case, but still outpatient therapy. And for that program specifically, the child had 1 appointment with me and the occupational therapist, and we would work together to come up with a treatment plan. And then the other appointment was specifically focused on parent training, so that the parent was able to implement the intervention. Because 2 times per week is not enough to change feeding behavior. The parent has to be able to go home and continue to practice. The other reason that we did this was if a child will eat foods in the clinic for the therapist, that's great. But if they don't go home and eat those, or they won't eat them in the community or at school, then that's not really helpful for that child. So we focused a lot on making sure that the child, anything that the child would eat in clinic, we generalized to natural settings. So Ethan and his mom attended 21 appointments. At the start of the program, he ate about 9 foods, but they were all brand specific, and he actually wasn't very consistent at eating those. So these are our treatment goals. I'm not going to go through all of them, but I wanted to provide examples. These are the goals that we had for the 12 weeks of the program. So they're very specific. We worked with the caregivers to prioritize what was important to them. And we always had a goal about parent implementation of the treatment protocol. Because again, our goal was that the parent would go home and be able to implement these and continue to do it after the program. So for Ethan's treatment, what actually happened at the beginning, they were having a lot of challenges at school. The family was having a lot of challenges at home. So during our baseline, there was high levels of challenging behavior. And before we started treatment, his mom said, I don't know if we can do this. I don't know if we can go through this. And so we, of course, said, that's perfectly understandable. You do not have to continue this treatment. There are times to work on things, and there are times to put them aside and focus on other things. And we said, if you want to discontinue, that's great, and you can come back. We can put you on the wait list, and when there's another opening, call you and you can come back. We said, or we could start really small and start with non-food related demands, because Ethan specifically had challenges with compliance with any demand, not just foods. So we said, we can see what we can build with compliance outside of meals. And then if that goes well, build from that. And his mom really loved that plan. So we had a lot of behavioral momentum. We used visual supports. He had a 1, 2, 3 board, contingent reinforcement for doing those activities. We tried to do preferred things. He in clinic really liked to work for dinosaurs. So I found dinosaur matching that was very easy for him. We had a lot of non-compliance to start. He actually wrinkled up the dinosaur and threw it to the ground and was mad and said I wouldn't do it. And then we just kind of waited, and eventually he uncrinkled the dinosaur. He apologized to it, said he was sorry and he'd never do it again, and then did the matching and then realized he got the reinforcement. There were 2 big things that were important. Well, actually 3. The first was escape extinction. So Ethan could get up from the table. He sat at a table. He could go around the room. He could go around the house at home, but the demand always stayed on the table. So even if he didn't want to do it, the food or the demand was there. And there was something we held contingent. In clinic, it was dinosaurs. At home, he preferred his technology. So that's what he would work for. And the demand was just there. And if he did it, he got his reward. If he didn't within the 45-minute session, it went away and you just didn't earn it that day. And then we would kind of regroup. The other components that were very successful was choice. He always had a choice of activities. So there was always a choice between at least 2 things, even when it was foods. And we would even do things like a mastered food. I'd give him a choice of 5 bites of chicken nugget, which he had eaten before, or 1 bite of the new food. So either way, we're working on a goal. We're either increasing the volume of a food we recently introduced, or we're introducing a new food, but he got to choose which one that was. And when we provided choices for him, it was incredibly effective. The other piece was that behavioral momentum, and we started with non-food related demands, and then we gradually built in the food demands. We had a schedule, and he knew we were going to try to do work, then break, then work, then break. And that was very ineffective for him. We tried to break the work down, but he knew work was coming back. He did better if we did all the work first, and then he knew the rest of the session, once he did his work, he could play. And once we implemented that, he would finish tasks almost immediately. So we had a protocol to introduce new foods, and then we had a way, once they were mastered, it included similar components, but a separate protocol for these are foods he's already eating. And this is how you run those kind of meal times. So he mastered 100% of his goals, both his behavioral goals and occupational therapy goals. We can go on to the next one. This shows the list of foods that he was eating. If they're bolded, he was eating those at baseline, and then all the other foods are foods we added. He also, we continued to do like once a week, every other week in fade services, and he continued to add foods and had like 25 to 30 by the time we completely faded out. We asked the parent at the beginning how big of a concern feeding was. This parent indicated it was a 10. It was their highest level of concern, and at the end of treatment was a 5. So it was a pretty significant change. And then how confident the parent felt, and it was a 5 at baseline and increased to an 8. This graph shows the percentage of bites that he accepted. So we have the baseline of the first 4 points, and the home, the way we took data at home was we provided a camera that the family would videotape the session and then bring back, and we would code it after. We did that because we wanted to make sure that changes that we saw in clinic, we were also seeing at home. So the first session, he actually did pretty well with bite acceptance. This was preferred and non-preferred foods, but then it dropped off significantly, especially at home. But you can see after treatment, we were 100% on all of our bites, both at home and in clinic. This was his rate of inappropriate mealtime behaviors. So for him specifically, that was yelling, falling to the floor, sometimes aggression, throwing things. And so you can see actually a very increasing trend for him. And then once we implemented the intervention, pretty low levels, although there was still some inappropriate mealtime behaviors, but a much more manageable amount for the family. And this last graph for Ethan is his time and seat. So he wouldn't sit for meals. So you can see the home, only 30% of the meal when they were trying to do this baseline was he sitting. Most of it, they were following him around the house trying to offer bites. It increased in their next session because they used non-contingent reinforcement without realizing it. They actually offered a preferred activity, an art activity that he had to do at the table. So he was very motivated to stay. He took a few more bites than he did during the other session of only preferreds, but he didn't try any new foods because of that, but he was able to sit at the table. And so you can see, again, it wasn't necessarily perfect all through treatment, him sitting the whole time, but significant improvements, and was able to stay high even as we introduced those non-preferred foods. We're going to jump to the next one quickly, and I'll just do this one quick. So the last example is Winona. She was a 4-year-old female diagnosed with autism spectrum disorder and feeding challenges. She attended the same program actually, and had 23 sessions, and her mother, father, and or nanny were present for all of those. At baseline, she actually wasn't really eating foods. We counted some before I saw her eat. She was actually taking the food out of her mouth and not actually, she would chew it, but not actually swallow it. So her numbers are a little off because actually she really wasn't consuming any foods at baseline. So these were her treatment goals. So we worked on some lower texture foods, so taking bites off a spoon. She is one that she had just started taking popsicle for the nanny off a spoon. She would kind of mush it up. And so we faded in yogurt. So we did a simultaneous presentation for her that was very successful. We did that because popsicle was recently added. It wasn't an established food. It wasn't necessarily for health reasons, so we felt like it was okay to kind of do this fading. And she's one we very gradually had to fade, but we were able to get some new foods at a lower texture that way. And then we worked on presenting small bites of food she was putting in her mouth, but she had to chew and swallow, and we tried to block her pulling it back out and playing with it. So like I said, we had the new foods protocol with the lower texture. So we did that, that fading, that simultaneous presentation with fading. We did what's called a stationary spoon. She did have a Riften chair at home, so they were able to kind of sit her and have the tray there so she couldn't just get up and down during the mealtime. But keeping it at her lip was challenging. She was pretty strong, and that's not something the parent could do without support. So the parent would present the bite in front of her mouth. When she took it, she got reinforcement, but if she didn't take it, it stayed there for a specific amount of time. And I think we started with a minute, but the family was able to go up to 5 minutes that they just kind of kept it there if she wasn't taking the bite. So she didn't immediately get that escape if she didn't want to take it, but she got reinforcement if she did. So we also did, like I said, behavioral momentum. We got her to chew and swallow bites of food she was already putting in her mouth. And then we were able to introduce new foods in the same way. And escape extinction there looked like we just kept the food on the tray because it was regular texture finger foods. She was self-feeding. So if she threw it, we just put another piece down. If she didn't take it, it just sat there until the time cap or until she took that bite and got the reinforcement. Once she was taking more foods, the family didn't mind having a video or something for her to watch. It was easier for them to do a response cost. If she refused to take the bite, they paused the video until she took it. When she took it, the video came back on. That was easier for them than pausing it, present a bite, you get your video, pause, present the bite. So they just had it running. As long as she was eating, she could watch, but they removed it if she refused. And we also worked on drinks with her as well, using a shaping procedure to gradually get that drink in. So she also mastered 100% of her goals. I'll show you the graphs quickly, or I think the food charts next. So again, the Cheez-Its, Goldfish, and Cheddar Bunnies, she actually really, even the Oreos and those Ginger Snaps, she really wasn't eating. The popsicle she was, and that was newly introduced. But we got her to eat all of those, and we're able to add several other bars, or several other foods, sorry, to up to 16. And she continued to add as well, and was eating things like pizza and things during our follow-up. So the parent rating of concern for feeding went from the highest concern of a 10 to a 6. And similarly, confidence, the parents went from a 5 up to an 8. This is her percentage of bite acceptance. So again, this was some preferred ones. We counted this as acceptance. I had a separate graph for expels, but I don't have it in here. So she would accept the bite, but she actually wouldn't swallow. So we targeted that first, but you can see acceptance increased to 100%, both in clinic and at home. And then the inappropriate mealtime behaviors, you can see we had some spikes. She still had higher levels of inappropriate mealtime behavior at home, but she was accepting the bites, and we were able to do some telehealth and support them after to work on those inappropriate mealtime behaviors there. Oh, I do have the expels. So this is how many bites she was expelling. So you can see it was very high at baseline, and she still had some. So anytime the food came out of her mouth counts as an expel, but significantly less than at baseline. Okay, now we'll get to questions. I apologize, I went a little bit over.
All right, Lori, thank you. So I will start. I'm just going to start with some of the earlier questions. Madalena asks, hi, I have a 5-year-old autistic son. He's actually a twin, but only Anthony has difficulty with food and eating. Firstly, he doesn't drink any water at all. He only gets his hydration from milk, and a milk bottle only. I've tried everything. He's under a dietitian, but we don't get enough help as my son is still not eating. He had 1 cracker today and 2 Skittles. He's nonverbal, not toilet trained, and suffers constipation. Any new ideas to try? Thank you so much.
Yeah, well, there's a lot there. One thing I would say, because it sounds like you said you weren't getting any support, and I don't know what is available, but working with a behavior analyst and or psychologist might be helpful to work on some of those behaviors. Since I don't know everything that you've tried, I might suggest things that you already have tried. But some of the things that I talked about today, so even just doing, if you're trying to transition to a different cup, doing it like if it's empty and just giving high rewards for just touching the cup to the lips with nothing in it, just to start getting familiar with that. With the food, it sounds like he's getting a lot of substance from the milk, and I'm not sure how much he's drinking. You could try, again, you can't take that away because that's where you're getting those calories and nutrition. But even trying to do, like, I offer food for a certain amount of time, and then if you haven't had it, you can have this milk, but if you eat even just 1 bite, you get your milk right away. I've done with a number of kids. If you're concerned about nutrition, it sounds like you're working with a nutritionist. One thing that I learned, even if you add like the Carnation instant breakfast, it provides a little bit of extra nutrients beyond the milk that can be helpful while you're trying to introduce foods, because it is something that's going to take time. So if you're concerned about the immediate nutrition, you may want to make some of those changes, but then kind of very gradually and start with really small goals. Again, it could just be interacting with a cup that's not the baby bottle and giving high praise and high rewards for that. And then starting to introduce even just like 1 sip or just touching it to the lips and then gradually increasing it.
Great answers, Lori. It's very hard to, certainly can't solve all the problems over a quick chat, but you can understand how challenging these situations can be.
Absolutely.
So we have a question from Anna, who has some challenges surrounding feeding with her daughter, who won't accept foods that require chewing. So anything, any thoughts on how to encourage chewing behaviors?
Yes. So I don't have any training as a psychologist and behavior analyst. I will tell you, they never teach you anything about chewing. So what I know about chewing, I have learned from occupational therapists and speech and language therapists. So if there is someone in your area who specializes in feeding, those might be helpful therapies to engage in. One thing that I have learned from them that I start with often, chewing is super complicated. I spend a lot of time thinking about now how I chew. Most of us do it automatically without thinking, but there's so much happening in your mouth. First, I tend to start with a molar placement chew, and I actually start with non-nutritive, so like the chewy tubes, like the T tubes, and you place it over the molars and have them bite down. You can gradually put food into the tube, like something like that's soft dissolvable, like a piece of a veggie straw or something, so that they're biting down and they get used to crumbs in the mouth, because crumbs are a component that are challenging. I've also done where we take graham cracker crumbs and you're just taking those bites off the spoon so that the child's used to the feeling. Purees and things stay together, crumbs scatter. And so that experience in your mouth is different. So getting used to the crumbs is another one you can do. From the T-tube, what I tend to do, I like veggie straws because they're long and you don't get your fingers crunched on, and they're soft dissolvable. So if the child bites off some, it'll dissolve in their mouth. You can also do graham crackers and cut into strips and hold them there and have them chew down. But another component is they have to be able to get the food from wherever in their mouth, use their tongue to get it to their molar to chew. So working on lateral tongue movements. So I've learned to do it with a lollipop if the kid likes that, or I've done various preferred foods, but even outside of the mouth, going from one side to the other so that they have control of their tongue. Unfortunately, chewing is a very complicated thing. And where the exact challenge is it the food over the mouth? Is it the tongue control? Is it the feeling of the food on the teeth? That's a little harder to discern, but those are some of the like early techniques that you could use to get things started. But again, working with a therapist to kind of figure out exactly what's going on for your child would be helpful.
Wonderful. And I agree. Until I had an interest in this area, I'd never thought about how complicated and how involved chewing is.
It is.
So we're coming up on time. I did want to ask one of these questions if you knew of a study that went through that syringe to open cup process.
Oh, that's a good question.
That's what I thought. So maybe you can just sort of think on that. And if you end up having one, I'm happy to do a search as well.
Yeah.
We can share that out.
Yes.
So
I can put a list for that.
And then I'll ask one more question, and then I think we have to wrap up so we can be respectful of everyone's time. But it looks like this might be actually from a provider, and it asks about how do you encourage a parent who might be giving a bottle of Pedialyte before the meal that might interrupt with other food intake.
Yeah, so I would start by asking the parent why they're choosing to do it that way, to get some understanding, because maybe in their experience, mealtime goes better if they're having the bottle first, or maybe there might be some reason. So understanding the parent's motivation first to do that, and that can help you kind of have a discussion about why it might be helpful to delay that bottle, that if there's some hunger, that the child may be more likely to take a bite. But until you kind of understand why they've decided to go that way, it's hard to kind of, you can provide all the information of why to switch, but it's important to ask, why is this working for you right now? What components, because maybe you can find some ways to shift or replace, or you only do part of the milk before the meal and then the bites and then gradually shift it.
All right, Lori. Well, I'm going to turn it back over to Jaden to wrap up. Jaden, we did have some questions about the presentation where attendees might be able to get information, contact information of Dr. Vincent. We also had questions we weren't able to get to. So Jaden, if you could just tell the members about that. And then as a reminder, we have another event coming up on August 26th. It's Bright from the Start, Ways to Make Brain Science Easier to Understand. And it's going to be with Dr. Jill Stam, and she's just going to be talking a lot about early childhood brain development and ways we can really stimulate and encourage tremendous brain development. Jaden, I'll turn it over to you.
Hello, everyone. Thank you for joining us today. And thank you, Lori, for a great presentation. I did record this, so if you would need it for any reference in the future or would like to share it with anybody who maybe couldn't attend today, that will be there for you. I will also attach the slides from the PowerPoint today, which I believe do have Lori's contact on them. And I do get a copy of all the questions, so I could always send that her way. But if not, then I am almost sure that her email was on the slide, so you could always reach out that way as well. And Lori, I will throw it back over to you if you just want to do any last closing regards.
Yes, thank you so much for having me. My email, hopefully it's on the slides, but if I didn't put it, it's just lori.vincent@uc.edu. And Rachel and Jaden, feel free to share that out. And I'm very happy to answer questions that we didn't get to. And I'm pretty sure that they published that. So I'll try to find that article for you guys to send out as well.
All right.
Thank you so much.
Thank you so much.
Thank you everyone for joining us today. Have a wonderful Thursday.